Chapter 29, Respiratory System Function, Assessment and Therapeutic Measures. Okay, so our learning outcomes describe the normal structure and functions of the respiratory system, identify how aging affects the respiratory system, list data to collect when caring for a patient with respiratory disorders, recognize expected findings when inspecting, palpating, percussing, and auscultating the chest. Identify common diagnostic tests performed to diagnose disorders of the respiratory system. Plan nursing care for patients undergoing each of the diagnostic tests. And discuss therapeutic measures used to help patients with respiratory disorders. First, let's go ahead and review our anatomy. Nasopharynx extends from the posterior nares to the soft palate. It contains openings for the right and left auditory eustachian tubes. This area, this is how babies get ear infections a lot because they're bottle feeding and milk or formula pools here. The oropharynx is a space between the soft palate and the base of the tongue. It contains the palacean tonsils, the ones most commonly removed by tonsillectomy, as well as the lingual tonsils found at the base of the tongue. The laryngeal pharynx passes the dorsal to the, excuse me, let me see if I can move this somewhere. The larynx and connects the esophagus. Anyway, so now that we reviewed the anatomy, just some more specific things you need to know would be the sinuses are up in the upper airway right here. The larynx is formed by 9 pieces of cartilage that keep it from collapsing. A group of ligaments bond the pieces of a cartilage together and adjacent structures in the neck. So this is important. It's kind of like the Adam's apple. It protects the trachea. It makes it difficult whenever we need to do a tracheostomy. Oftentimes they go underneath the cartilage a little bit to do the tracheostomy. Also, the vocal cords are protected as well, and they are also in this area. And this is the vocal cords. These are what we utilize as landmarks when intubating patients. Okay, so we have to visualize the cords. We go past the cords and go into the trachea right here. Now the trachea is lying just in front of the esophagus. The trachea is a rigid tube about 4.5 inches long and 1 inch wide. Its C-shaped rings of cartilage encircle the trachea to reinforce it and keep it from collapsing during inhalation. The open part of the C faces posterior, giving the esophagus room to expand during swallowing. The trachea extends from the larynx to the cartilaginous ridge called the carina. And then we have the bronchial tree. The bronchial tree is at the carnate to the trachea, branches into 2 primary bronchi. Like the trachea, the primary bronchi are supported by C-shaped rings of the cartilage. The right bronchus is slightly wider and more vertical than the left, making the most likely location for the aspirated food particles and small objects that lodge. Immediately after entering the lungs, the primary bronchi branch into the secondary bronchi, and for each of the lung lobes, since the left lung consists of 2 lobes, it has 2 secondary bronchi. The right lung has 3 lobes, so it has 3 bronchi. Secondary bronchi branch into smaller Tertiary bronchi and the cartilaginous rings become irregular and disappear entirely in the smaller bronchioles. So they collapse easy. Without cartilage, they do become more flexible. They do become also more vulnerable. So tertiary bronchi continue to branch, resulting in very small airways called the bronchioles, less than 1 millimeter wide and lacking any supportive cartilage. Bronchioles divide further to form thin-walled passages called alveolar ducts. So here we got the right lung, right? The right lung is shorter, broader, and larger than the left lung. It has 3 lobes, the superior, middle, and inferior, and handles 55% of the gas exchange. The right lung contains 2 fissures, the horizontal fissure and the oblique fissures. So you see how one goes diagonal and one goes straight across. So the top of the apex of each lung extends about 1/2 inch above the first rib. Okay. Ribs, their purpose is to protect the lungs. Sometimes they cause more harm. Because the heart extends towards the left lung and has only 2 lobes, the superior and inferior, it contains 1 fissure, which is the oblique. See how it goes diagonal? And the base of each lung rests on the diaphragm. Here's the diaphragm. Okay, so now we're talking about the alveoli. The alveoli, is where all the gas exchange really happens. They're wrapped in finely mesh of capillaries. The extremely thin walls of the alveoli and the closeness of the capillaries allow for efficient gas exchange. The exchange of air occurs through what's called the respiratory membrane, which consists of the alveolar epithelium and the capillary endothelium and their joined basement membranes. Okay, so what happens is we have deoxygenated blood going through, and then we have red oxygenated blood coming out. And all this is happening in the exchange where the right side of the heart delivers it to the lungs, the left side of the heart takes from the lungs. Okay, so they kind of have to have an even preload and outload, okay, to oxygenate effectively. That's why left-sided heart failure or right-sided heart failure is going to affect lung and air exchange so much. So now we have inspiration. The external intercostal muscles pull the ribs upward and outward, widening the thoracic cavity. And then the diaphragm contracts, flattens, drops, pressing the abdominal organs downward, enlarging the thoracic cavity. Air rushes in, equalizing the pressure. So as we expand the lungs, we are putting pressure on the rest of our body parts to allow that to happen. And then on expiration, the internal intercostal muscles pull the ribs downward as the external intercostal relaxes. The diaphragm relaxes, bulging upward and pressing against the base of the lungs, producing the size of the thoracic cavity. Reducing the size, of the thoracic cavity. Air is pushed out of the lungs. Makes sense? So acid-base balance, respiratory acidosis, is usually caused from hypoventilation, not enough oxygen, too much carbon dioxide. And respiratory alkalosis is too much oxygen and too little carbon dioxide. The effects of aging. The aging respiratory system, sometimes we have weakened and atrophied respiratory muscles, reduced elastic recoil of the lung tissue, deteriorating cilia, decreased cough reflex, reduced effectiveness of alveolar macrophages, and reduced number of alveoli. Air trapping is more happens more often with the elderly, and a decreased force of cough because they don't have the muscle in their diaphragm any longer. So all of this is going to lead to decreased gas exchange and increased risk for respiratory infections. So a health history: upper respiratory system symptoms, lower respiratory symptoms. Um, have you ever been exposed to asbestos? Did you smoke? How much did you smoke? How long did you smoke? Are you still smoking? Um, what are you doing now? Are you on any asthmatic inhaler treatments? Are you taking oxygen regularly? What's your family history? And so what's up is a good one. Where is it? How does it feel? Is there any aggravating or alleviating factors? Timing. This is about pain too, but it works well for respiratory symptoms as well. So inspect the patient. Does the patient have a barrel chest? Is the patient using external muscles to breathe? Meaning, with every breath, are they having retractions? Retractions is when you could see their ribs with every breath, like they're using muscles to breathe, external muscles to breathe. They have nasal flaring. Can you see there's intercostal, which is when your ribs, you could see the ribs. There's also subcostal, is when their stomach collapses during each breath. Yeah, so that's basically retractions. I'll have to show it to you, but like this guy right here, if you could see his clavicle. This is called subclavicle retractions. If you could see those with every breath, that's a problem, you know. And I'm not talking about you're so thin that they stick out all the time. No, that's not it. Whenever you see a breath and then you see those intercostal areas because they're using all this muscle to breathe, that's a problem. Also, color. Are they turning gray, blue, purple? And also pay attention to the membranes. It's not always skin. By the time it gets to the skin, it's already pretty advanced. So now we look at the respiratory rate and rhythm and the chest shape. Remember I was telling you barrel shaped is usually from long-term COPD because of using external muscles for so long. Sinuses, we want to palpate. If you've ever gone into the doctor because you have a headache and your face feels like it's going to explode, the first thing they do is push down on it kind of rough, and it makes you jump because it hurts so much. That's a sinus infection, okay? That's their sign. Respiratory excursion and crepitus. Crepitus is when you push down on something and you feel like Rice Krispies, like air gets trapped even in the skin sometimes. That's usually a really, really advanced sign as well. Percussion, resonance, hyperresonance, and dull and flat. So if they suspect that you have fluid trapped in your lung space, they may try to percuss the lower areas and see if they can determine if that it's a different sound made when percussed. Auscultation. I want you to take note about all the different areas that you would listen in the front. Up here is obviously not where the lungs are, but we can hear fluid phlegm that's trapped in these areas. So sometimes if the patient has to cough, you're going to hear these wheezing, gurgly sounds throughout the whole lung fields, and you'll have to tell the patient you need to cough before you start. Okay. And then, of course, you might want to listen underneath the armpits because sometimes you can get good adventitious lung sounds. Now, you see down here, this is what I don't understand. And I will call you on it every time you do it. We don't have lung sounds past 7. This all the way to 8, you're listening to the kidneys. So don't do that. Listen to 7, maybe 6 or 7. Around the bra line is where we're listening, okay? Any further than that, you're listening to kidneys. Yeah, so keep that in mind. Adventitious breath sounds, crackles, coarse or fine, wheezes, stridor, friction rub, diminished lung sounds, and absent lung sounds. You see, whenever we're listening to asthmatics, we hear wheezing, and we usually find that to be a good sign because wheezing means that there is still gas exchange. Um, when you don't hear wheezes on an avid asthmatic, likely they are not having any gas exchange, and that's a medical emergency. Lab tests to complete are your CBC, ABGs, D-dimer, culture and sensitivity, oxygen saturation, and capnography. Capnography would be your CO2. Capno means carbon dioxide. Like if you're capnic, you're reliant on um, your capnic drive means you're relying on your CO2 levels to take a breath. And as we know, CO2 is not a drive any longer for COPD patients. So they're oxygen driven to breathe. So your diagnostic tests is your chest x-ray, your CT scans, ventilation perfusion scans, pulmonary function studies, pulmonary angiography, and bronchoscopies. Smoking cessation is a big part of patient teaching when it comes to respiratory disorders, behavior modification, counseling, setting a quit date, nicotine replacement, drug therapy, hypnosis, physical activity, and e-cigarettes. They have a few drugs now that help with smoking cessation. Chantix, although it's not recommended for patients who have psych issues, and also Wellbutrin, which is recommended for patients with psych. It's a antidepressant, so those are supposed to be helpful in smoking cessation. Therapeutic measures, deep breathing and coughing, huff coughing, autogenic drainage. Autogenic drainage. I don't know what that is. But anyway, breathing exercises and diaphragmatic breathing, pursed lip breathing, tripod breathing. That's when you sit forward like a tripod, and that's supposed to help expand your lungs as you take breaths. It's you see people do it after they run large marathons and they're trying to get a large amount of oxygen in their body. Positioning. Okay, people with lung issues cannot lay down flat. They can't. So always they always have to be in fowlers or semi-fowlers, or sometimes they have to be leaning over a bedside table. They really cannot lay down flat. It's like they can't breathe. So typically you'll see them sleeping in recliners, sleeping in their wheelchair. Here's oxygen therapy by nasal cannula. You can deliver up to 6 liters of oxygen via nasal cannula. If the patient needs more than that, you'll have to go into a mask. A mask delivers anywhere between 6 and 10 liters. And anything past a mask would be like a Venturi or, let's see what it does for us. Here we go. A non-rebreather mask has a little balloon at the end of it for an oxygen overflow storage. These are partial rebreather masks. They're kind of the same thing technically, but these are important if you want to deliver large amounts of oxygen. Like if somebody was on 100% oxygen, they would have to be put on a non-rebreather or Venturi mask. Because a nasal cannula and a simple surgical mask are not going to cut it. So transtracheal oxygen, we can put something called like a tent. Here it is, a chain necklace, a tracheal catheter, and a trachea. Look at that, there's your trach. So typically we can deliver oxygen pretty effectively by just putting it through this tube and into the trach. Uh, Sometimes whenever people are on tracheas, they have to be intubated as well. So they have a mechanism for that too. That looks to me like it's the suction catheter, but oftentimes they'll put a mask over the trachea for oxygenation. Okay. Here's a nebulizer treatment. We give out a lot of these. Um, some patients are on like every 6 hours for asthmatic relief. Meter dose inhalers. It's important that you wait 2 minutes in between each inhaler. It's also important to make sure the patient rinses their mouth after taking steroids because it can cause thrush. So you want to use a spacer. You want to shake, put it on their mouth, and give a breath. Let them inhale it out, and then do it again if it's a 2 puff inhaler, and puff. Okay, so you always want to give the bronchodilator before giving the steroid, okay? Because that will help the patient expand their lungs so they could take the steroid and get more surface area covered with steroid. It just makes it more effective. Just make sure after the steroids and in between each steroid and inhaler, there's at least 2 to 5 minutes. There you go. There's our spacer. All right, so an incentive spirometer typically used when we want patients to expand their lungs, usually after um, surgery to prevent pneumonia or during pneumonia to help facilitate air exchange and to help decrease atelectasis. Um, they're always a good thing to have, and for most patients that are going to be not moving around very much for a couple of days, because all these patients are going to be at risk for pneumonia. So pretty easy. You're trying to suck air in. It's measuring how much air. It's gauging how much, and you want to tell the patient to try to get more and more each time they do it. That way, it's like a competition. It's kind of an inside joke. Like all they need to do really is deep breathe and cough. But we tell them, oh no, keep trying to get your lungs, more and more expanded, and that helps them take deeper breaths, right? It helps them take breaths more often because now there's a goal. Oh, and these are chest physiotherapy where you do percussions on the back to try to loosen up phlegm and so it can get coughed up. Vibratory positive expiratory pressure, that's your PEP. That's basically air that keeps the alveoli a little bit open. Okay, I don't know what this is. Other measures are high frequency chest wall auscultation of the vest and a thoracentesis. So if you believe that there's fluid in the pleural space, oftentimes we have to get that drained out so that the lung can expand. Chest drainage is indications would be a pneumothorax or a pleural effusion or pleurisy or an infection of the pleural space or fluid or trauma or any kind of thing could be an indication that there's putting tension on the lungs and we need to empty out the pleural space. A chest tube inserted will help drain any fluids. If it's air that's causing the lung to collapse, then we put it higher. We put the chest tube higher so the lung can expand. It's a drainage system just like a catheter or anything else. We need to keep it lower than the chest wall at all times. We want to make sure that the air leak chamber isn't showing any bubbles. We want gentle titling in the tidal section portion. We want to see, keep it upright. Don't let it fall over. It needs to be strapped to the frame of the bed. Um, and no dependent loops. We can't do any milking. Those are just common NCLEX situations that might come up. Here it is, water seal chamber, suction chamber. This doesn't really do it justice, but the drainage goes here and collects in these three. And we measure them each shift for intake and output. It is part of the intake and output. So we need to get data collection. We need a patient. We need tubing. We need a drainage system. We need to fill up the water seal chamber with the water provided. It's usually it's not sterile water or anything. We can use tap water, but it's got like a blue tinge to it, so you could see fluctuations, because usually it's a white. It's just harder. It's easier to see when the water's blue. The tracheostomy is a tube inserted into the opening of the trachea to maintain patency. Indications would be like, say their throat got swollen, or they're going to be on a long-term ventilation system. We can't leave it through the oral area. We usually will put in a trach for long-term intubation. Suctioning, cleaning, and communication and teaching are all really important with trach care. So here's the metal tube that we utilize. Sometimes we use a cuffed to help. If it's cuffed, then the patient's not going to be able to talk, because that puts pressure on the around, so air can't come through. If air can't come through, they can't speak. It takes air to speak through vocal cords. And then, or there's a fenestrated tube, which the patient will be able to talk through. So our nursing diagnoses for a tracheostomy would be ineffective airway clearance, risk for infection, impaired verbal communication, disturbed body image, and deficient knowledge. So this is the, I don't know what, Passimura speaking valve. What it basically does is it, like patients who've had their larynx taken out or their vocal cords taken out for usually cancer reasons or smoking or things like that, they have this little valve where they can talk. They put this vibrator thing on to take the place of the vocal cords, and it will talk for them. They sound kind of like robots, though, kind of weird. But here's intubation. Um, Nurses don't intubate. Luckily, we have respiratory therapy who kind of specialize. This is all they do. This is their job. The airway, securing the airway is their focus. Thank goodness, because I don't want to do that too. Physicians also intubate, but as nurses, we don't have to intubate. I do know that like paramedics under dire circumstances also perform intubations. So mechanical ventilation is when we're basically breathing from, see, she's long-term mechanical, so she has a trach that does that, you know. It is invasive. The indications would be they're not able to breathe on their own for whatever reason. That could be a brain injury. That could be, most of the time it's brain injury if it's long-term. It could be exacerbation of COPD. Remember, we have to keep patients' COPD levels between 88 and 92, but it drops below 88. We can't give them more oxygen to bring it up. So they have to be intubated. There's no way around it. Remember, troubleshooting alarms. High pitch would mean that there is a blockage, and low pitch would be an indication that it's leaking, that it's either it's not attached, or they're not getting any oxygen. So for nursing care, check advanced directives. Use the team approach, monitor the patient, keep the head of the bed raised 30 to 45 degrees, provide oral care with chlorhexidrine. This is to prevent a VAP-associated infection. Suction as needed, and assist with communication. Non-invasive positive pressure ventilation. I was talking about this earlier today, where they put the mask on whenever patients are just not quite bad enough to be intubated or they're DNR, but we want to give them treatment. This would be utilized for that. It's just positive pressure. It's just forced air going into your mouth and nose. It can be very drying. It could also be increase a lot of anxiety because you're basically putting a mask and strapping it to your face. People, though, oftentimes are used to this because of their CPAP, and that's another positive pressure ventilation technique used. So CPAPs are used because of um, sleep apnea at night. So some of them are used to it, but a lot of patients have a hard time with this for long term. So what occurs in response to negative pressure in the thoracic cavity? Okay, negative pressure in the thoracic cavity would be exhalation, I think. Okay, I don't know if that was right or not, but number 3. I can't really go back easily. Let me look. No, it doesn't let me. Okay. Next one, which acid-base balance results from impaired respiratory function? Well, we know it's respiratory, and likely it's going to be acidosis, because remember, impaired means less oxygen, more CO2, and CO2 is the acid. Which adventitious breath sound is generated by narrowed, inflamed airways? That would probably be wheezes, but yes. What is the best method to recommend for smoking cessation? Nicotine replacement is a good thing. Drug therapy and behavior modification, hypnosis, setting a quit date. I think it's like all of them except for 3. I think 1, 2, 4, and 5. Behavior modification. Come on now. Oh, it's all of them. I stand corrected. Which intervention can help patients expectorate sputum? Select all that apply. Antihistamines are drying. They're not going to help secrete. Vibratory positive pressure, yes, this will. Oxygen, no, it's also drying. A room humidifier will, and huff coughing will. So maybe 2, 4, and 5. Yep, finally.